You have had a blood test, possibly many, and at the end of each one your doctor looked at the results, told you whether things were normal or not, and moved on. But here is what most seniors do not know. The reference ranges printed on your blood test results, the numbers that say normal in green or flagged in red, were not designed specifically for you. They were not designed for your age, your gender in many cases, your medication history, or the interaction between multiple values on the same result sheet. They were designed for a broad statistical population, and applying broad population statistics to an individual senior with a specific health history is where the interpretation of blood tests most commonly goes wrong. Today, we are going through 5 specific numbers that appear on almost every standard blood test, numbers that look fine on paper, numbers your doctor likely told you were acceptable, and we are going to explain what those numbers are actually telling you, and why the standard interpretation may be missing something important. This is not about criticizing your doctor, it is about giving you the information to have a more complete conversation at your next appointment. Number 1. Your hemoglobin or hematocrit. This is the measurement of your red blood cells, the cells that carry oxygen throughout your body. The standard reference range for hemoglobin in older adults is typically listed as 12 grams per deciliter or above for women and 13.5 grams per deciliter or above for men. If you are at 12.1 as a woman or 13.6 as a man, your result comes back as normal. Green. No flag. No discussion. But here is what the range does not tell you. Research published in multiple geriatric medicine journals has consistently shown that even mild anemia, hemoglobin levels that are technically within the normal range but sitting near the bottom of it, is associated with significantly worse outcomes in older adults. Faster cognitive decline, greater fall risk, reduced physical function, higher hospitalization rates. The number is not normal for you simply because it clears the statistical threshold. A hemoglobin of 12.2 in a 70-year-old woman who was previously running at 13.8 represents a meaningful decline, even though both numbers sit within the normal range. The trend matters as much as the absolute number. What to do with this? At your next appointment, ask your doctor, what has my hemoglobin been over the last 3 years? Is it trending down? Even within the normal range, a downward trend in hemoglobin in a senior deserves investigation. It can indicate early kidney disease, nutritional deficiency, chronic inflammation, or blood loss that has not been identified. A static normal is very different from a declining normal, and the printed result does not tell you which one you have. Number 2. Your TSH, your thyroid-stimulating hormone. This is the standard test for thyroid function. The reference range printed on most blood test results for TSH is approximately 0.4 to 4.5 millunits per liter. Some laboratories extend this to 0.3 to 5.0. A result anywhere within that range comes back as normal. No flag, no discussion. But the evidence around TSH reference ranges in older adults is one of the most actively debated areas in all of endocrinology. Multiple large studies, including work published in the Journal of the American Medical Association, have found that TSH levels naturally tend to be slightly higher in older adults as a normal part of aging. The reference range, however, was established largely using younger populations. This creates 2 specific problems. The first is overdiagnosis. An older adult with a TSH of 4.2 may be flagged as borderline hypothyroid and offered treatment, when that level may be entirely appropriate for their age and their thyroid may be functioning normally. The second, and more important for most seniors, is underdiagnosis of a different pattern. A TSH that is low or at the very bottom of the range, 0.4 to 0.8, in an older adult is not automatically reassuring. In seniors, a suppressed or low normal TSH can indicate a mild overactivity of the thyroid that is associated with significantly increased risk of atrial fibrillation, the irregular heart rhythm that multiplies stroke risk, as well as accelerated bone density loss and cognitive effects. Yet a result of 0.5 comes back as normal. Because it is within range, what to do with this? Ask your doctor specifically, where exactly is my TSH sitting within the range, and has it changed direction, up or down, over recent years? A TSH trending lower over successive years in a senior deserves closer attention than a single normal result suggests. Also ask whether your free T4 and free T3 have been checked alongside TSH. TSH alone is a screening test. In seniors with symptoms, fatigue, weight change, heart rhythm irregularities, cognitive changes, the free thyroid hormones provide a more complete picture. Number 3. Your eGFR, your estimated kidney filtration rate. This is the measurement of how efficiently your kidneys are filtering waste from your blood. The normal threshold is typically listed as above 60 milliliters per minute per 1.73 square meters of body surface area, A result of 62 comes back as normal, green, fine, not discussed, but the eGFR is calculated using a formula that incorporates age as a variable, and this creates a specific problem that most seniors are never told about. Because kidney function naturally declines with age, the eGFR formula partially adjusts for this. So an older adult with genuinely reduced kidney function may receive an eGFR calculation that clears the normal threshold precisely because the formula has adjusted for their age. In practical terms, this means an eGFR of 62 in a 75-year-old represents meaningfully less functional kidney reserve than an eGFR of 62 in a 45-year-old, even though both results clear the normal threshold. The number that matters alongside the absolute value is the trajectory. An eGFR that was 78 3 years ago, 71 2 years ago, and 62 today is a kidney that is declining at a rate worth investigating, regardless of the fact that 62 clears the normal threshold. In addition, many seniors are on medicines that are processed by or can damage the kidneys: NSAIDs, certain antibiotics, some blood pressure medicines, contrast dyes used in imaging. The dosing of many of these medicines should be adjusted based on real kidney function, not the population-adjusted eGFR figure on the result sheet. What to do with this? Ask your doctor. What has my eGFR been over the last 3 to 5 years? Is it declining? At what rate? And do any of my current medicines need dose adjustment based on my kidney function? That last question is one that slips through in busy routine appointments more commonly than most patients realize. Number 4. Your fasting glucose. The normal range for fasting blood glucose is typically listed as below 5.6 millimoles per liter in the UK or below 100 milligrams per deciliter in the US. Prediabetes is typically defined as 5.6 to 6.9 millimoles per liter or 100 to 125 milligrams per deciliter. A result of 5.5 or 99 comes back as normal, green, fine. But there are two significant limitations to fasting glucose as the sole screening test for blood sugar problems in seniors, and most seniors are never told either of them. The first limitation: fasting glucose is a snapshot. It measures your blood sugar at one specific moment, first thing in the morning after at least 8 hours without food. But blood sugar problems in seniors most commonly manifest not in the fasting state but in the response to eating. A senior can have a normal fasting glucose of 5.2 while having post-meal blood sugar spikes that reach 9 or 10 millimoles per liter, levels associated with significant cardiovascular and kidney damage that are never detected by fasting glucose testing alone. This is why HbA1c, the 3-month average blood sugar, is a more informative test, and why a 2-hour glucose tolerance test catches abnormalities that fasting glucose entirely misses. The second limitation: the reference ranges for fasting glucose were established largely on younger populations. Multiple studies have shown that older adults who are metabolically healthy tend to have slightly higher fasting glucose than younger healthy adults, simply as a consequence of age-related changes in insulin sensitivity. Applying the same threshold used for 40-year-olds to 75-year-olds leads to both overdiagnosis and underdiagnosis depending on the direction the individual deviates from that threshold. What to do with this? Ask your doctor. When was my HbA1c last checked? Not just my fasting glucose. The HbA1c, a result below 5.7, is normal. 5.7 to 6.4 is pre-diabetic. 6.5 and above is diagnostic of diabetes. This one additional test catches blood sugar problems that fasting glucose misses entirely in a significant proportion of seniors. Number 5. Your PSA for men, or your bone density T-score for everyone. These are two separate tests, but they share the same critical interpretive problem. For men, PSA, prostate-specific antigen, is used to screen for prostate cancer risk. The standard reference range lists PSA below 4 nanograms per milliliter as normal, but the PSA threshold of 4 was established based on general population data. In older men, the prostate naturally enlarges and produces more PSA as a baseline. A PSA of 3.8 in a 75-year-old man may represent a significant elevation relative to what is expected for his age-specific range, while a PSA of 4.2 comes back flagged when it may actually represent normal age-related change. Age-specific PSA reference ranges exist. They have been published in peer-reviewed literature for decades, and using them meaningfully changes the interpretation of the result. But most standard laboratory reports still use the flat threshold of 4, regardless of the patient's age. The more diagnostically useful measurement alongside absolute PSA is the rate of change, called PSA velocity. A PSA rising from 1.2 to 2.8 to 3.6 over 3 years in a man who was previously stable is more concerning than a static PSA of 4.1 that has not changed in 5 years. The first pattern requires urgent investigation. The second warrants monitoring. The standard result sheet tells you neither. For everyone, bone density T-scores from a DEXA scan classify bone density as normal above -1, osteopenic between -1 and -2.5, and osteoporotic below -2.5. These thresholds were established based on a reference population of young white women at peak bone density. Applying them universally to men, to non-white populations, and to adults of different body compositions introduces significant inaccuracy in both directions. What to do with this? For men, ask your doctor what your PSA has been over the last 5 years. Ask about the trend rather than the single number. Ask whether your age-specific range has been considered. For bone density, ask whether your absolute fracture risk has been calculated using a tool called FRAX, F-R-A-X. This is a validated calculator that uses multiple factors beyond just the T-score to estimate your actual 10-year fracture probability. It is what should be guiding treatment decisions, not the T-score alone. Here is the single most important thing to take from this video. A normal result is not the same as a good result. Normal means you cleared a statistical threshold designed for a broad population. It does not mean the number is optimal for your specific age, your specific history, your specific trend over time, or the interaction between multiple values on the same result sheet. The questions that extract the most useful information from blood tests are not simply, is this normal? They are, what was this number last year and the year before? Is it trending in a direction? Does this number interact with any of my other results or my current medicines? And what would need to change about this number for it to require action? These are not complicated questions. They do not require medical expertise to ask. They require only the willingness to ask them. Take your last blood test result to your next appointment. Ask about the trend of each value over time. Ask whether the reference ranges used are appropriate for your age. And ask whether any of your current medicines need to be reconsidered in light of the complete picture. That conversation, properly prepared for, is worth more than any single test result.